Hi, everyone. Welcome to Orthopod. I'm here with a friend and colleague, Dr. George Utwal, who is a professor in the Department of Surgery, a shoulder and elbow surgeon, and currently works at Western University in Canada. Hi, George.
Yeah. Hello, Dr. Bender. How are you?
Very good, thanks. I'm going to spend about 5 minutes, if I can, sharing some slides of about 3 papers with you, and I will do that very quickly. And I'm hoping afterwards just to get your take on this. And I think probably the easiest way to do it is I'll just kind of get through the slide deck, and then maybe we can have a short little discussion around what the content is. I know you're well aware of this literature pretty well, and so I think we'll be able to mostly just kind of let our viewers know what we're talking about and then go from there. So we're going to talk a little bit about displaced radial head fractures. And within that, there are 3 questions we're particularly interested in. What works best for these displaced fractures in terms of internal fixation or arthroplasty? If we're going to be using arthroplasty, is a fixed or a non-fixed, we can call loose-fitting implant going to be optimal? And quite frankly, are all implants created equal? Those are the 3 questions that these 3 papers aim to evaluate. And the first paper that came out roughly, earlier, early mid last year, was a network meta-analysis, and there's been tons of work done on network meta-analysis. But the gist of the storyline was that when we look at specifically displaced radial head fractures, that arthroplasty results tended to have better outcomes, broadly speaking, than fixation. Now, either fixation with the metallic or bioabsorbable implant. So this was based, again, not necessarily on all randomized clinical trials. There were some trials and a lot of observational data sets, but that was the gist of that particular paper. Not that long after, though, there was another paper that came out in late 2018 or so that had another interesting conclusion. And they said, well, listen, if we look at all of the radial head arthroplasty implants that have been used for displaced fractures, it turns out that we think that the overall rigidly fixed implants are at greater risk of having revision surgery than the smooth stem spacers, or what they call the unfixed designs. So actually, suggesting, in fact, that if you're going to choose a type of radial arthroplasty, you might be looking at an unfixed design. But interestingly, when you looked at the conclusion, rightly so, they said, hey, listen, there are areas where we're not 100% sure. And the truth of the matter is that, in our meta-analysis, we didn't look at all of the causative factors that would have been potentially interesting to do so. So that led our group, and obviously with your collaboration, the impetus to say, okay, it's quite plausible that, in fact, not all fixed implants are created equally, and there might be heterogeneity, which basically means differences between implants or designs that would potentially lead to different outcomes. So this led to the third paper in this systematic review series that looked at the core work that had already been done, and then said, okay, can we look at those causative factors that might be potentially influencing these outcomes? And in short, there were a couple of key findings. One was, there's going to be different types of indications that are just going to have greater complication rates. And that was one key finding of that work, that when we look at the overall complication rate with one particular approach, there were differences overall with respect to, complications, in this case, revision, specifically with the terrible triad. And finally, you can see this design here, but finally, the other point that was of interest was when you looked at the range of designs that were included in this literature. And again, these are mostly non-RCT data, but when you looked at that, you could see that if you were to clump all of the fixed, implant outcomes together as revisions, you would get somewhere in the 10 to 12% range. But you can see it went very, very widely, anywhere from a few percent all the way much past 60%. We also learned that there are many implants that just aren't even in circulation anymore. They've been discontinued. So that's the challenge I think we find when we do work in radial head arthroplasty research or in these areas, where if you're looking over time, there's all kinds of challenges to pull in data. So that kind of has been what we've been learning. And I guess the question is, because the data isn't all RCT data, it may not be the most robust data sets, but it is the best we have. I'm curious, George, from your perspective, what do you make of all this?
Yeah, I mean, I think it's really important is to understand where all this data is coming from. And
Right.
what we have to understand, just as you identified that there's this heterogeneity in the implant types, that makes sense. I mean, we know that with anything that's manufactured, cars. I mean, there's like you have your Mercedes Benz, and then you may have your Kia, your Ford Escort, and those are not made equally. And if you call them a car, one's
Yeah.
maybe perform better than the other.
Yeah.
But going back to even the foundations of the materials, and you look at the patients that we select, there's such a high degree of heterogeneity within the patient population, as you identified in that last slide.
Yeah.
And that provides a huge amount of bias as we go through all of these studies. So when we look over time, our patient indications have changed, and those implants have also changed. Specifically, when you look at the indications, and I look at when we do a radial head arthroplasty and compare that to fracture fixation, in those more complex cases where we have ligamentous injuries, fractures of the coronoid, other associated injuries, what we term as complex elbow instability, we know that those radial head fractures are more comminuted and more damaged. And so they tend to do, with that bias, they tend to do
Yeah.
better with an arthroplasty. In many cases, those younger patients, we're trying to fix them. We really want to fix them, but we're
Yeah.
fixing a fracture that's one of the most challenging fractures to fix. It's osteopenic, it's comminuted. And so you can kind of get a story of why sometimes open axial internal fixation may not do as well in those complex cases where the arthroplasties tend to do better.
Oh, it's very interesting. And what's your take on this huge range between types of fixed devices? Is there any gleaning? Is there any message from that you would glean?
I think the more anatomic the fixed devices, I would, it would, your sense is that it's probably better. That, I mean, if we can recreate anatomy anatomically with an
Right.
implant, that would seem better. The challenge in lies is how do we recreate that?
Right.
And what we find is that if you have very well established techniques on understanding of the anatomy of a surgeon that's experienced and that can place the implant into its anatomic position, I would suspect that those patients and those implants are probably going to do better. So I think it has a lot to do with technique, implant design, and surgeon experience.
And if you were to now think about what the fourth study would look like, what would be like what needs to be sorted out in the area of radial head fractures that, where we still need more? And I guess the argument could be, well, it would be lovely to get, bigger studies and more data on what we already have so we can be more confident about the results. But are there burning questions that need to get answered in this area that you've been thinking about?
Well, I mean, I guess I have a little bit of a biased patient population that
Yeah.
we tend to see, or I tend to see sometimes the complications of non-operative management.
Yeah.
And so, although there's Scandinavian literature that says that, for type twos and stuff like that, and
Yeah.
some common
Yeah.
ones we do not have to operate on. I mean, I'd like
Yeah.
to really know, like I think we should be really identifying that
Yeah.
2 millimeter, 3 millimeter, 4 millimeter displacement to see, they may do better with surgery, but we don't know. And I think that needs to be investigated.
That's interesting. And probably as a last question for you is, like, in the time right now where we are seeing delays to access, for what we're calling non-urgent, orthopedic surgery, there's probably going to be a greater pressure or a greater revisiting of non-operative care, generally speaking, because the backlogs are just going to get bigger, and we're not likely to see these changes, go back to what we're calling pre-COVID norms for months. Some people are arguing maybe over a year. Has that changed your practice and the way you think about radial head fractures? I mean, like you just made a point around the non-operative treatment. Are you going to be more likely to be pushing patients on the bubble for non-operative treatment in an environment where access is just harder to get all our time?
It's a very good question. I must admit, I have tried not to let the COVID crisis change my indications.
Okay.
And so what I do is I discuss it more so with the patient. So if I say like pre-COVID, this is something
Yeah.
that I would probably lean towards an operation.
Right.
In the present COVID crisis, are you willing to put up with the risks of coming into hospital to have a surgical procedure done? And I leave it up to the patient to decide.
Right.
And if they feel that they want to proceed ahead with surgery, I feel very comfortable doing it. I don't want the COVID to change my indications for surgery because I feel that I may then have to deal with the repercussions of that down the road.
Oh, I mean, it's an extremely logical approach to use. I'm just curious of whether patients themselves are now backing off, especially those that are vulnerable and at risk, right? They're thinking, well, you know what, I'll just wait. I'll wait it out. can it wait an extra while? Do you think it'll be okay? Are you getting those kind of comments or no?
Yeah, I think you're right.
Yeah,
That is happening. We see patients that are coming in at they're still painful at 2 to 3 weeks. Now they're getting the X-ray done and identifying a fracture.
yeah, yeah,
And
yeah.
there's some reasonable literature. I mean, we did a case control series looking at acute versus delayed radial head arthroplasty, and we found no difference. So it would lead me to think that if we do wait a little bit of time, it's not the outcome's not going to be horrendous. It's not may not be substantially different. But certainly as surgeons, it's much easier to operate when fractures are acute.
Oh
They
yeah, yeah, yeah,
reduce
yeah.
a little bit easier, everything's a little bit easier. And in that
Well,
subacute period, sometimes some of the complications, heterotopic ossification stiffness, tend to go up.
well, I mean, this has been a short podcast, but I can tell you it's been highly, highly informative. I can't thank you enough, Dr. Atwell, for taking time to, help us through some of these issues. These are focused issues, but we really appreciate your expertise and time.
No, I got to say thank you, Dr. Bendar, for educating us. I mean, you have such an amazing ability to educate the world, and I'm not sure if you get enough recognition for it, but really, I enjoy reading your papers and working with you.
It's been awesome. Thank you so much again. Appreciate it.